The body will do everything it possibly can to protect the core. The core is the heart, the brain, and the lungs. So all of our other vital organs, such as our kidneys, and all the organs in our gastrointestinal tract, those become what I call second-class citizens. They get less perfusion because the body is again trying to protect the heart, the brain, and the lungs. When the pericardial effusion happens slowly over time, the body, as with many other conditions, has tremendous abilities to compensate. People often ignore the fact that they're having chest pain, or they say, oh, it's something else, it's indigestion, it's the Taco Bell I ate yesterday, and they don't come to the hospital. And that's why more and more people die at home after having a heart attack. It's because they ignore their symptoms or they wish it away. Then it's not going to go away. So reinforcing to recognize that you are at risk and the symptoms that require immediate action are the things that I like to emphasize with patients and their families.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are talking with ONS member Roberta Kaplow, Clinical Nurse Specialist at Emory University Hospital in Atlanta, Georgia, and member of the Metro Atlanta ONS Chapter, about the latest nursing management and prevention strategies for cardiac tamponade. This episode is part of a series about oncologic emergencies, and the previous episodes are linked in the episode notes. You can also earn free NCPD contact hours by completing the evaluation we've linked in the episode notes. Thanks for joining us today, Roberta.
Thank you for inviting me, Stephanie.
So to start us off, can you give us some background on cardiac tamponade? What is it? How does it present? Those sorts of things.
Sure. So in order to understand what's happening with cardiac tamponade, I have to take you on a journey back to nursing school where we had anatomy and physiology, and we learned about the heart being surrounded by what's called a sac. It's a pericardial sac. And the pericardial sac has some lubricant in it, about somewhere between 10 and 50 milliliters of fluid, and it serves as a protection for the heart and again for lubrication. There's always this 10 to 50 milliliters of fluid available in the pericardial sac for that lubrication. But for a variety of reasons, which I'll get to in just a few moments, sometimes the amount of fluid in the pericardial space increases and can increase in large amounts. When the amount of pericardial fluid increases, that's called a pericardial effusion. When the amount of fluid in the pericardial sac gets to a certain point where the patient is experiencing hemodynamic compromise, that's when the patient has a cardiac tamponade. So cardiac tamponade is on the right end of the spectrum, the severity end of the spectrum of a pericardial effusion. It gets manifested in a number of ways. Patients can report lightheadedness. They may have some referred abdominal pain or atypical chest pain, depending on where the pressure is being referred. The patient may have cough or hiccups or some hoarseness in their throat. From a hemodynamic perspective, the patient will have some hypotension and tachycardia. They can report shortness of breath. They may have jugular venous distension or JVD. If the patient goes into cardiac arrest, obviously they will have absent heart sounds, but if they're just having tamponade without cardiac arrest, their heart sounds could be distant because you won't be able to hear them through all the fluid. The patient can also report what's called the pulsus paradoxus or a paradoxical pulse, where they'll have a decrease in blood pressure when taking a breath in.
Roberta, thanks for taking us back to nursing school. I think it's really important to understand the whole process and what we're going to be dealing with. And this definitely sets the groundwork for us as we go forward in this discussion. So, are there certain patient populations that are at a higher risk for developing cardiac tamponade?
That's a great question, Stephanie. Yes, there are a number of patients at risk. So any patient with metastatic cancer, specifically related to pericardial involvement, so patients with lung cancer or breast cancer or malignant melanoma, those patients have a higher risk of having pericardial involvement, thereby putting them at greater risk for the development of cardiac tamponade. But also our treatment modalities, patients receiving chemotherapy, radiation therapy, or biotherapy are also at risk. So patients receiving drugs such as busulfan or cytarabine, cyclophosphamide, fludarabine, doxorubicin, docetaxel are at risk. This is not an all-inclusive list. In terms of immunotherapy or biotherapy, patients on tyrosine kinase inhibitors such as dasatinib, or the anti-PD-1, PD-4 regimens, such as patients on Pembro or nivolumab, those patients are also at risk.
Great, thank you. I think that those are really good points to bring out. And thanks for telling us what those risks are, not only related to their diagnosis, but also to their treatments. And I think for oncology nurses, there are so many treatments that you have to know and understand. And you're thinking about the general side effects that patients normally have with that, but then to add this on as something that could be a potential side effect or problem with some of those treatments, I think it's just such a great review. So what etiologies can lead to cardiac tamponade?
Well, in addition to the metastatic cancer and all the treatment modalities, patients with an infection can develop cardiac tamponade. Again, journey back to nursing school with me for just a moment, and I won't go into great detail with this, but patients with infection or with sepsis can develop an inflammatory response, which will make their vessels dilate and fluid leaking from the vessels into the third space. In this case, the third space is the pericardial sac. So again, the fluid will accumulate. But also patients with renal failure or heart failure, a myocardial infarction, patients, trauma victims, or patients with hypoalbuminemia, low albumin levels are also at risk. Those are other etiologic factors, because with low albumin levels, for example, albumin is a protein that has a primary function of pushing fluid from the third space back into the vasculature. And if the albumin level is low, there'll be decreased pressure to get that fluid back into the vessels where it belongs. So patients with low albumin levels will have third spacing of fluid, but it won't be able to be returned to the intravascular space.
So if an oncology nurse notices some of these causes, how can recognizing these things help that nurse identify and manage cardiac tamponade in the early stages?
Well, as with any oncologic emergency, early recognition is mission critical. The main hemodynamic effects, as I mentioned earlier, are hypotension and tachycardia. So if the patient is hypotensive for a prolonged period of time, and there's always this magic number of, let's say, 30 minutes of hypotension, that will mean that end organs will not be perfused. When the body is in shock, which means there is an imbalance between oxygen supply and oxygen demand, for example, from hypotension, the body will do everything it possibly can to protect the core. The core is the heart, the brain, and the lungs. So all of our other vital organs, such as our kidneys, and all the organs in our gastrointestinal tract, those become what I call second-class citizens. They get less perfusion because the body is again trying to protect the heart, the brain, and the lungs. So the shorter amount of time that the patient is experiencing hypotension, and the earlier that the oncology nurse recognizes and implements therapies, supportive therapies, which we'll talk about, the better the outcome is going to be for that patient, and the patient will suffer less comorbidities.
Okay, great. So now that we've talked about the causes and the patients that are at risk, let's talk about how this is diagnosed. If you are a nurse taking care of a patient and you've had some of these etiologies come up, what is the actual diagnostic process for a patient with suspected cardiac tamponade?
The first thing that would probably take place, the patient will be reporting shortness of breath. The immediate response by the provider is likely to be, well, let's get a chest film. And so the chest film won't show very much. The one classic symptom it does show, though, which is so hard to find on the internet, it's so hard to find a picture of this, but I try to have a close, not even a close picture, but the best I can find picture is the heart takes a shape called a water bottle heart. And again, it's difficult to find, but that's literally what it should look like. Again, difficult to find, so chest x-ray probably will be non-conclusive. The next thing the patient will probably undergo is an ECG, because the patient will typically report atypical chest pain. We have to rule out an acute MI, myocardial infarction. The findings that we'll see in cardiac tamponade on ECG is a low voltage QRS, which is typically the tallest wave in the electrical pattern of the heart, and is now much smaller, and the patient may have peak T waves. So sometimes the T waves are taller than the QRS complex, which would be a classic symptom of, or symptoms of cardiac tamponade. The gold standard for diagnosis of cardiac tamponade is an echocardiogram. So it's the use of ultrasound waves, sort of like pregnant women checking on the status of their baby in utero. They'll use sound waves to see the pericardial sac, and they can estimate how much fluid is in there. And then they'll also be able to tell how well the heart is functioning.
So, Roberta, let's talk about the complications that occur with cardiac tamponade.
So the main complications we see are related to the hypotension that exists. If the heart is not pumping adequately, there'll be less oxygen delivery to the cells, organs, muscles, and tissues, and that can lead to multiple organ dysfunction syndrome, what we used to call multi-system organ failure. Again, anytime the patient is hypotensive for 30 minutes or more, that's when the kidneys start getting affected, as well as the GI tract. The brain is also very sensitive to changes in oxygen and carbon dioxide. So if the patient is being hypoperfused, there'll be mental status changes that can take place. That's not necessarily meaning brain damage, because again, the body is doing everything it possibly can to protect the core, but you have to worry about all the other organs that are being hypoperfused and could go into failure as a result of that hypoperfusion or hypotension.
Thinking about everything we've talked about so far, the patients at risk, the causes, how it's diagnosed, is this something that happens quickly with patients? Or, for our nurses that are listening, is this something that might be a gradual side effect or, emergency that happens, versus, a bleeding episode that might happen very, very quickly? What does that look like for patients?
That's a great question too, Stephanie. So with an oncologic emergency, cardiac tamponade occurs typically very slowly. So there may be a small amount of fluid accumulating as a result of any of the etiologic factors. I remember a patient that I was caring for one time who used to be not admitted, but he would come to our procedure area like every 6 weeks, and we would drain 1.5 liters from his pericardial sac. He would have a drain in place where we would have to drain him a liter. It was literally 1.5 liters every 6 weeks. So he never developed cardiac tamponade because we already knew his pattern of how quickly he accumulated fluid, but he developed a large pericardial effusion. When the pericardial effusion happens slowly over time, the body, as with many other conditions, has tremendous abilities to compensate. So when it happens quickly, such as a trauma victim where you stab somebody in the chest, then in that situation, a bucket of blood is going to fall into the pericardial space at a moment, and there's no chance for the body to compensate at all. So that patient's going to go into cardiac tamponade very, very quickly. Same thing with a motor vehicle crash and an unrestrained driver. So those patients will develop cardiac tamponade very quickly. Whereas a patient with an oncologic diagnosis, those patients are going to accumulate that fluid much more slowly, and body will have a certain amount of ability to compensate for the increased fluid in the pericardial sac. And so the patient may not develop hemodynamic compromise for a long time. So again, with this gentleman who I remember caring for in the procedure area, he just knew when the 6 weeks was up, he was going to get into trouble if he waited more time. And in he comes, we put him in a bed, we put him on a monitor, we drain him, we watch him for a little while, and he goes home on his merry way. And that's how he had to live his life. But he never went into, the first time he went into cardiac tamponade, we recognized him. We said, all right, we're going to monitor you. And now we knew how to take care of him for that amount of time. It was great.
Great. Thanks for explaining that, because I think, when we hear oncologic emergencies, we think of something immediate. And so to understand that this is something that is a gradual thing that patients can experience is, I think, an important thing for us to remember and for our listeners to hear, because a lot of those complications or how you recognize it are things that are other side effects to other things too. So, you really are having to think about, okay, ruling everything out. So we've talked a lot about of what it looks like and how it presents. Let's talk about the treatment interventions that are used to manage cardiac tamponade now.
Okay, great. So initially, when a patient is suspected of having cardiac tamponade and they are being worked up, the patient is going to need some supportive therapies. The two that come to mind are oxygen therapy, because again, they're going to have some shortness of breath, as well as some fluids. Remember, the fluid is coming from the intravascular space and is now going into the third space. So the patient is essentially becoming hypovolemic, even though the fluid is not actually leaving the body. It's going to a place where it can contribute to hemodynamics. So fluid therapy and oxygen therapy are first. For the treatment of the pericardial tamponade itself, we can do a couple of things. Depending on where the patient is, if the patient is in, for example, the intensive care unit, the initial treatment and the most recognized treatment is what's called a pericardiocentesis, where the provider will insert a needle that goes subxiphoid underneath the xiphoid process, and they'll use echocardiogram so the needle can be, guided into the right direction, and the fluid will be removed with a syringe in a sterile procedure, of course, to eliminate the tamponade. We don't have to remove every morsel of fluid. Again, we want to have a normal amount of fluid, that 10 to 50 milliliters left approximately in the pericardial space, but fluid will be withdrawn with the needle and a syringe at the bedside. Now, we're not going to do that on the patients on a general medical floor or, general oncology unit. The patient will probably have to go to the operating room for that. So that's gold standard. Sometimes, well, many times actually, as in the gentleman that I spoke about earlier, the pericardial effusion recurs and the patient develops cardiac tamponade again. If that happens, there are a few options open to the providers. So they can do what's called a pericardial window, which is just a communication between the pericardial space and the intrapleural space. They make a little patch, they stick a catheter into the pericardial space that will get attached to a sterile drainage bag, and we could drain the pericardial fluid, and when the amount of fluid reaches the level that the provider is happy with, that typically happens within 3 days to even 4 weeks, 28 days. Then the catheter can be removed in the operating room again. If this is going to be a recurrent thing, we're not going to keep a catheter in the patient's heart for the rest of his or her life. We may have to do some sclerosing therapy. So what happens with sclerosing therapy is a substance is injected into the pericardial space, and this substance is acting as an irritant. And when something gets irritated in the body, it forms like scar tissue. So in essence, what's happening is scar tissue is forming in the pericardial space. That's leaving no room for fluid to reaccumulate because there's only scar tissue there. So there are a number of sclerosing agents that we have available. I remember when I started my career a few decades ago, We used to use talc, which is the same substance that you would used to use on pleural effusions, which was associated with a lot of pain. So we try to be kinder and gentler with patients these days. So now we're using other substances. We're using corticosteroids, we're using tetracycline, and actually tetracycline is pretty commonly used, but they're also using chemotherapeutic agents such as anthracyclines or bleomycin, cisplatin. They're using nitrogen mustard or fluorouracil, thiotapamitamycin C. Those are some of the agents they're using as sclerosing agents. And again, they're forming scar tissue, so there's no room for pericardial fluid to reaccumulate. If they don't want to go that route, plan C might be to do a pericardial peritoneal shunt to help prevent recurrence. Or finally, the most drastic, I'll call this plan D minus, is a pericardectomy, where they literally remove the pericardial sac. If there's no pericardial sac, there's no place for the fluid to accumulate. Very aggressive surgery, and now the heart doesn't have a place where it's getting lubricated and protected. So they don't take that decision lightly.
Wow, thank you for that. So for our listeners, we have a lot of new to oncology nurses as well as just new nurses. What are some really important nursing considerations for patients who are experiencing cardiac tamponade, as well as with those interventions you just talked about?
Probably the biggest thing for any nurse, new, not so new to oncology, not so new to oncology, is know your patient who's at risk. And we talked about those. And if you think the patient has the symptoms, call and ask for help right away, because the prompt supportive therapy with oxygen and fluids right away, possibly the use of vasoactive agents if the patient doesn't respond adequately with blood pressure. Those are all the things that are going to make a huge difference in terms of the patient's outcome, in terms of morbidity and mortality. So don't doubt yourself, especially if you knew, oh, I'm new here, I don't know if this is it, I may be reading more into this. No, trust your gut. I tell people this each and every day. Trust your gut. If you think the patient's at risk, you do it.
That's great. And I think that's important. Again, like I said, because there are so many side effects and just symptoms that are similar for so many different things, I think it's really important to hear that and be able to think about that when you're getting to know your patients a little bit more and finding out what their specific nuances are, let's say. So, are there any gero-oncology considerations that would need to be taken into consideration for cardiac tamponade?
Sure, and I agree on your previous statement as well. Yes, again, if you journey with me back to nursing school for just a moment, I won't go into specifics, but I remember in my program, they spent a good amount of time talking with us about the pathophysiologic changes that occur with aging. It's kind of depressing. They start around age 30. It's really depressing. But, as you get older, because of these pathophysiologic changes, the patients have more risk for developing complications, morbidities, or even mortality. So if the patient has cardiac tamponade, they're more likely to die when they're older, especially if treatment is delayed. Patients can also be at increased risk for kidney disease because the body's not as resilient when we get a little older. 30 minutes of hypotension in a 30-year-old patient versus 30 minutes of hypotension in an older adult may have different sequelae. So again, it just brings us back to the same point we've both been driving home, which is trust your gut, early intervention, early diagnosis are both mission critical for patient optimal outcomes.
Yeah, Roberta. And I think too, as you were mentioning about, that gero-oncology patient group, the reality is that's probably a majority of our patients, that are coming in newly diagnosed or patients with long-term treatment diagnoses. So it is something that's really important to think about with that group. What education should oncology nurses provide to patients who are at risk for cardiac tamponade?
The biggest and most important things to tell patients and their families or their significant others is to understand why they are at risk in the first place, and then what symptoms to report. Patients tend to think, oh, I'll just wait, I'll ignore this and maybe it'll go away. And they really, it's one of those things that can turn on a dime. So if the patient is experiencing symptoms that possibly may be related to cardiac tamponade, they need to get to the hospital as soon as possible. They shouldn't delay. They shouldn't ignore it because, if somebody has chest pain, this is the big thing with the American Heart Association. People often ignore the fact that they're having chest pain, or they say, oh, it's something else. It's indigestion. It's the Taco Bell I ate yesterday. And they don't come to the hospital. And that's why more and more people die at home after having a heart attack. It's because they ignore their symptoms or they wish it away. Then it's not going to go away. So reinforcing to recognize that you are at risk and the symptoms that require immediate action are the things that I'd like to emphasize with patients and their families.
Roberta, it has been so great talking to you about this today. I can just hear how excited you are, and just your expertise in this area, I think, is going to really help all of our listeners. And I appreciate all that you have provided for us. And I like to end all of our podcasts with a few questions that we do roll in a quick fire manner. And so I'm going to start those now. And the first one is, what are common misconceptions about cardiac tamponade?
There are probably two misconceptions. One is, I call it one and done. So people think that, okay, they warned me about this cardiac tamponade thing. I had it taken care of. I'm done with that one, move on. But it can happen over many times. So it's not one and done. It can happen again, and the symptoms going to be the same, and the actions for survival are the same. So please don't one and done it. It's going to happen again. The other misconception I didn't mention earlier in the symptoms because it's a misconception, but there's a set of symptoms called Beck's triad. And Beck's triad are three symptoms: hypotension, jugular venous distension, and muffled heart sounds. And I remember when I was taught this in nursing school, you had to have all three. Yeah, you get all three of these things, and oh, that's how I know you have cardiac tamponade. But all the recent literature supports that Beck's triad hardly ever happens. And so don't wait for that because you're waiting too long.
Next, what's something about cardiac tamponade that's not often discussed, but you wish people knew more about?
I think that people don't realize that it really is an emergency that can really happen to them. And I think sometimes people live in denial that, first of all, they have cancer. When they come to that realization, well, nothing, this treatment is enough, this treatment isn't, I'm dealing with it, I'm taking care of it. But it's just, you have to deal with it. That's the biggest thing, I think, for me.
The next one is, what additional training or education do oncology nurses need to manage patients with cardiac tamponade?
In addition to knowing what the signs and symptoms are and what to look for and which patients are at risk, if it's, again, maybe particular to the nurses in the intensive care unit now, how to assist with a bedside pericardiocentesis. It's a sterile procedure, so we had to make sure everybody, all the providers are on the up and up with their sterile precautions, but knowing where to attach the limb leads and onto the needle that's going into the patient's heart, knowing where that is. Watching the echocardiogram during the procedure is fascinating because you can actually see the provider driving the needle into the pericardial sac. Before we had the privilege of using or echocardiography, the providers were going in blindly. And if there was a lot of fluid in the pericardial sac, there's a good chance they'll hit the right spot. But if there wasn't a lot of fluid, but the patient developed cardiac tamponade anyway, they were hitting the ventricle. And that, of course, was not good. So learning, how to assist with the pericardiocentesis, and then watching as the fluid is removed, how the patient's hemodynamics improve and the symptoms improve at the same time. That would be very valuable.
And lastly, what are some additional resources for both patients and providers who want to learn more about cardiac tamponade?
Well, for the providers, there is a wonderful book. It's actually an ONS book. It's Understanding and Managing Oncologic Emergencies, and the editor is Marcel Kaplan. That book has a lot of wonderful information. It's explained beautifully for nurses at all levels to understand what's happening with cardiac tamponade. For patients, I like actually homegrown in the hospital, patient education materials, because that's going to be specific to what the patient's going to experience and what that patient's at risk for at that specific place. I try not to encourage people to go to the internet. They're going to go anyway, but I try to encourage them not to do that because, first of all, it's not at an appropriate reading level. And even if you're a Rhodes Scholar, when you're dealing with a cancer diagnosis and now an oncologic emergency, that's not the time to be reading things at an inappropriate reading level. There'll be misunderstandings, and it's not appropriate information. And you can't always control what's going on in the internet. So I try to I like the evidence-based, homegrown patient education materials. There's also the National Comprehensive Cancer Network, NCCN, that has education for patients and families, and that's evidence-based, that's peer-reviewed, that's up to date, and I love that for patients and families and for providers as well.
Roberta, again, I'd just like to thank you for joining me today for such a interesting and excellent podcast with information about cardiac tamponade for our listeners. You've been a lot of fun to talk with and listen to, and just your knowledge on this has been wonderful. So thank you so much for joining me. Do you have any final comments for us today?
Just my favorite pearl of wisdom is that, as with all of the oncologic emergencies and with patients with cancer in any way, meticulous nursing care is essential for patient survival and other optimal outcomes. So just, you're doing such an awesome job. Thank you for all you do. And it's been a privilege to work with you today. And hopefully you find this helpful.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.